patient comes to our attention with the precise request for complete coverage of the two recessions on elements 31 and 41. From the anatomical situation and from probing, it's possible to see that the recessions are pure and can be classified as a Miller second class. The interproximal peaks are perfectly preserved, and the surgical technique chosen is the modified Allen tunnel. The surgical operation starts with an incision using a scalpel, blade 12, within the sulcus on the mesial aspect of the two incisors in order to precisely cut off the gingival and transeptal fibres. A non-beveled, perpendicular, horizontal incision is made at the level of the papilla between elements 32 and 31, whilst on the mesial face of element 42 a back incision is made. The same sort of incision is made on the mesial face of element 32. Still using a number 12 blade, incisions are made within the sulcus in order to be certain that the circular and transeptal fibres have been perfectly cut off. The two papillae distal to elements 41 and 31 are raised with total thickness by means of a CTGO up to the mucogingival line, subsequently using a number 15 blade, passing to partial thickness until the papilla is completely free, allowing it to rotate above the vestibular face of the gingival recession on the two elements. Mixed thickness flaps are raised. Once the papilla on the mesial aspect is freed, using a 15C blade, the papilla is undermined to create a tunnel, below which the connective tissue graft will be passed, firstly in a distal mesial direction, and then the papilla between elements 31 and 32 is raised, firstly with total thickness and subsequently with partial thickness apically to the mucogingival line. Continuing with a 15C blade to undermine the papilla between the two incisors, and then proceeding with a number 12 blade, which will make it easier to cut into the underlying papilla and consequently raise it. Great care must be taken not to cut it off. With a periodontal probe, it's possible to see how the tunnel has been created, and keeping it slightly raised, it will be possible to improve the incision, which must extend well beyond the mucogingival line in an apical direction. Coronally, it must allow the sliding and lifting of the coronal papilla as regards to the ameliocementan line of the teeth. Having prepared the flap, the roots must now be prepared for planing. In this case, it is carried out with a 40 micron fine-grained diamond burr. With this burr, planing is carried out so that the root is perfectly clean. Using blade number 12 to go over the incisions again and make them bigger in a mesial and distal direction, always strictly partial thickness, to create two pouches within which the connective tissue will be positioned. This tissue will be removed from the palate by means of a classical technique. In this case, after having made an incision perpendicular to the bone ridge, using a dissector to perfect this incision, and changing the inclination of the scalpel, going from perpendicular to parallel in the palatine vault, following the long axis of the teeth. Re-entering the same incision to reduce the thickness of the mucous fibre in the palate, going in a mesial distal direction and penetrating in an apical coronal direction with the help of surgical pincers. The flap is opened and entering with a scalpel, carrying out a perpendicular incision at the base of the thinning previously carried out, and therefore cutting off the periosteum. Entering the first incision with a CTGO chisel instrument and using levering movements, the connective tissue is lifted out and placed on a gauze soaked in physiological solution, and suturing can begin. It is a crossed suspended horizontal mattress suture with a vestibular knot. The needle is passed distally to the sixth in the interproximal space, between the sixth and seventh, and apically to the thinning carried out in the palate. The palatine tissue is caught in a mesial direction and comes out in the interproximal space. This is a crossed suspended horizontal mattress suture. In fact, it is suspended on element 16, where the fixing knot will be carried out vestibularly. First, the thread is wound in a clockwise direction, the second time anti-clockwise, and for the third time, clockwise again. A fourth knot can be made to perfectly stabilize the flap. The second suture stitch is started by passing the interproximal space from the vestibule to the palate, where the needle came out previously. The needle passes through the interproximal space, entering the palatine area, pulling the thread and again catching the thickness of the palate in a mesial distal direction to have a good anchoring in the thickness of the fibrous mucus. Pulling the thread, the needle returns vestibularly in the space between the two premolars. Another horizontal mattress suture is carried out, a suture which is suspended and crossed palatally and making a stabilizing knot on the vestibular aspect. The fundal aim of this suture is to exert pressure and traction on the flaps, and is an effective way of keeping hemostasis under control at the palatine level. The thread is cut, and the third stitch is started, passing through the interproximal space between the two premolars, catching the palatine tissue on the mesial aspect with a horizontal mattress suture in a mesial distal direction, firmly anchoring the tissue. The needle exits vestibularly to a mesial tooth, that is, between the premolar and the canine. Again, the vestibular knot is made. Suturing continues in this way using a crossed suspended horizontal mattress stitch up to the most mesial aspect of the incision. Once suturing has been completed, it is advisable to position a surgical dressing over it for protection, which in any case doesn't have any open parts. The connective tissue which has been removed is now placed on the receiving bed. It's possible to see the ample dimension which is more than enough for the required gingivectomy. If, as in this case, it is necessary to thin it, the tissue is placed on an ivory plate. Holding it firmly, the tissue is modelled, removing adipose tissue until the correct shape is obtained. The tissue is passed through the tunnel, adapting it perfectly to the site by means of simple interrupted sutures. It is adapted to the amelocementum junction in such a way that the flap can't go down in a coronal apical direction and be lost in the vestibular depth. Simple sutures are carried out, passing from the vestibular to the palatine space, going around element 41, exiting on the vestibular aspect. This suture is made using a resorbable thread because it will remain below the papillae, which will be rotated, and in this way any interference due to the removal of the suture is avoided. Therefore, for these reasons, a resorbable thread is used. Returning to the lingual aspect, the thread is pulled. It has been anchored both mesially and distally to the connective tissue in front of element 41. Returning to the vestibular aspect, the stabilizing stitch is carried out, a continuous suspended stitch. At this point, the two papillae will be clearly positioned in the centre of the gingival recession. The connective tissue graft will have vascular support from the integral papillae, which formed the tunnel through which it was passed, as well as from the two papillae in the interproximal spaces distally to the two central teeth, which will now be sutured by means of a simple suspended suture in the centre of the gingival recession on the respective teeth. The most difficult point to vascularize is the most curved part of the recession. Here, where it would be difficult for the vascular bridge to form, the papillae, which was rotated for half a tooth, is positioned, and this will provide further vascular support exactly in the area where it is most needed, without a periosteum bed, unlike above it. The papilla is caught using a very thin needle and thread. This is very important because this is almost microsurgery. Otherwise there's the risk of lacerating such a small and delicate piece of tissue, which would be difficult to suture for a second time. In these cases there isn't a second chance. Therefore it is fundamental to carry out these sutures with suitable instruments. A knot is tied in an anti-clockwise direction with thin threads, a second one again anti-clockwise, and the papilla is stabilized right in the centre of the recession, providing further vascular support in an area which doesn't have much vascularization. Once the papilla has been stabilized, the same suture technique is used to also stabilize the papilla on the vestibular face of element 41. As delicately as before, therefore using very thin needle and thread, the papilla is caught keeping 1 millimeter from the gingival margin, from the incision line, passing from the vestibular aspect to the lingual aspect. The needle returns to the vestibular aspect through the interproximal space of the two central teeth. Again the thread will be delicately pulled on the vestibular aspect, and firstly the papilla is caught. Then the new simple suspended suture will be carried out in reverse, correctly positioning and stabilizing the papilla on the vestibular face of the flap, the first in a clockwise direction, the second in an anti-clockwise direction, and the third in a clockwise direction, so as to block the papillae, and here it is possible to see that the suture has been completed. This suture exerts pressure on the alveolar mucus at the vestibular level, reducing any dead space due to the fact that previously the tissue had been lifted with partial thickness, thus reducing the thickness of the coagulum and making faster and better healing possible. Here it is possible to see the situation before treatment and healing after 2 years and the coverage obtained.